Okay, well, let's get started here today. We want to keep you at an hour. Welcome everyone, and thank you for attending Strategies of Managing Myopia, a closer look at this growing epidemic. Our speaker tonight is Dr. Nick McColley. Nick received his BA in biochemistry and optometry from Indiana University. He then joined Texarkana Eye Associates, where he practiced in Texas, Arkansas, and Oklahoma, including expanded scope in Oklahoma. Nick received his MBA from Texas A&M, Texarkana, and was named Texarkana's Chief Medical Officer, where he helped grow their practice from 3 to 12 locations in 3 years. Nick became the Clinical Field Director of Integration for My Eye Doctor when Texarkana was acquired by My Eye Doctor. In this role, he helped with the acquisition and integration of new offices from the professional services perspective. Missing the atmosphere, the quality, and care of private practice, Dr. McColley moved back to his hometown and joined Hancock Eye Associates, a 2-doctor location in Greenfield, Indiana, just outside of Indianapolis. He currently is a key opinion leader for X-CEL Specialty Contacts and devotes his time to primary care optometry with an emphasis on dry eye and specialty contact lenses, including Ortho-K and scleral lenses. So again, welcome, and I will turn it over to Dr. McColley.
Thanks, Kathy. So here today, we're talking about strategies of managing myopia with X-CEL's new product, the REMLens for orthokeratology. Kathy, can you just see the main slide there?
Yes, I can.
Okay, perfect. Okay, so I assume that many of you joining this webinar know what Ortho-K is, at least at a 10,000-foot view, but we'll talk a little bit about Ortho-K in general, how to fit Ortho-K patients, what is a good Ortho-K patient, and then also how to implement it into a practice setting, because sometimes we think, implementing something new is a little bit too difficult or time consuming because of how busy we are in our own clinics. So Ortho-K in and of itself is a compression of the central cornea overnight with a GP lens to reduce the corneal steepness to try to reduce what the patient realizes as myopia. Why do we do it? Well, there are several reasons. I myself do it, and I do it because I'm a very, very difficult patient in more than one way, but I am very soft contact lens intolerant. My sclera is too steep vertically to fit into a scleral lens, and I'm a -2 myope, and I just want to be able to see without any aids, and I don't want to have to go through the procedure of LASIK because I'm terrified it's going to make me even more dry than I already am. We also use it in children, obviously, to reduce myopia progression. And that's kind of where we started implementing it in our practice. And then we decided how we could best evolve to fit it into a larger patient demographic. So talking about the REMLens, it falls under the Boston Orthokeratology VST approval, so FDA approval that Bausch & Lomb started. It's approved on label up to a -5 spherical myopic patient with up to 1.5 diopter of cylinder. It works much better with rule astigmatism than against the rule astigmatism, so keep that in mind. If you have somebody with 1.5 diopter of with the rule, may be easier than a diopter against the rule. It's made of the Equilens 2 material, which is a DK of 85, and it was approved for daily wear, extended wear, and overnight Ortho-K. In our practice, we use red and yellow lenses, red for right because it's easy for patients to remember. And actually in the left, we switched to blue just because it was a little bit easier to see. Once you thin down that lens blank, it can sometimes become a little bit too clear when it's a yellow. So why even discuss myopia management at all, right? Because in our practices, we can fit myopic patients in soft lenses and they're happy as can be. Well, vision, as we know, isn't always healthy, right? You can be 20/20 but not have a healthy eye. So myopia, every advancing diopter of myopia creates new problems, or the opportunity for new problems. So there's a very, I'll say, famous in our community graph down there at the bottom right that shows the odds ratio of these issues, these cataracts, retinal detachments, and myopic maculopathy, in different buckets of myopia. And as we can see, as you push down in each subsequent bucket, your odds of getting a cataract, retinal detachment, and myopic maculopathy greatly increase. And in fact, if we can slow down myopia by 1 diopter, we get a 40% drop in myopic maculopathy. And that's not just saying 1 diopter total, we can actually compound on that, and every diopter is a 40% drop from the previous diopter. Other issues related to axial elongation, hindrance of activities of daily living from high prescriptions. You know, this is an issue that's near and dear to my heart. It's actually why I got into optometry, because my dad is a -12. And he did have an RD when I was in high school, and just going through that whole process with him was pretty eye-opening. And as somebody that was his kid and could see where it was going, I was a little afraid of how my eyes would be. Now, I got lucky. My sister did not get as lucky. And had we had the technology to slow that down, or at least the availability, because more fitters were fitting this, you know, my sister could have had a much lower prescription than she currently does. So the idea behind myopia management is that in a myopic patient, you have a focal point that should land on the retina, but instead it lands inside of the retina because the corneal curvature is too great. And that actually creates an arc of light. So we always focus our corrections on how does light focus on the macula, because that's when the patient feels that they can see the best, because that's where all of the visual acuity comes from. However, we still get light rays in from the pupil in other parts of the retina. So when we correct somebody with glasses or contacts, we actually get this arc that lands outside of the retina for the focal points from non-axial light rays. Now, there's some debate on how this actually works, but the idea behind it is that the eye sees that if you can't flex the ciliary body to make that light clear because it's going the wrong direction, then its only option is to grow. And so there's some sort of feedback cycle that help the eye grow to catch up to those peripheral light rays. And the idea behind Ortho-K, distance center multifocal lenses, is to bring the light inside of the retina in the peripheral areas so that that cuts that feedback cycle for the eye to grow. Again, there's various theories on how orthokeratology actually flattens the cornea, but there's some evidence to say that it's a redistribution of epithelial cells that moves them out more towards the periphery. It could also be morphological changes in the cells themselves that squish down or compress or stretch out towards the outside of the cornea. And some evidence that shows that it goes deeper than the epithelial cells. It actually goes into the stroma and creates different molding or remodeling. And that one's kind of an interesting one because that one has a little bit more long-term consequence, right? Epithelial cells get replaced every week or two. Stroma is there, and once it's there, it's there. And I have a colleague who, you know, he believes that his daughter started as a -2 in Ortho-K. She wore Ortho-K for many years, and when she got done with Ortho-K and washed out, she was a -1. Now, there's other factors that go into that. That's an anecdotal experience, but it is an interesting thought. So why do we want to even make the effort in our practices? Because this is a time-consuming skill, and it is a skill that not everybody is going to have in your community. So why make the effort? For me, it's lifelong positive effects on children, right? If they would have done this to my dad, maybe he wouldn't have had that retinal attachment. Another reason is because other people are doing it, and you don't want to be in that situation where parents have heard about it, their friends have heard about it, they're worried about their kids because they know how their eyes are, and they leave your practice because you never even talk to them about it. So you want to be able to stay competitive with the newest ideas, technology, and practices in your area. And then also it's a consistent revenue stream. It is in our practice, it is a strictly cash pay type of procedure. And we don't have to worry about insurance. We can create our own global fees, our own structure to help patients. And these patients are going to come back to you because this is a niche type of thing, and they can't just go down the street to another practice or a commercial practice and be able to fit these quite as well. And even if they do, they're kind of starting over. So it locks patients into your practice as loyal, happy patients. So you're starting this world of Ortho-K, or you're looking to expand it, and you're looking at how do I choose an Ortho-K design? There's so many designs out there. It kind of depends on how you want your practice to run. How do you want it to fit? Are you going to fit empirically, meaning giving your Ks and refraction to a consultant where they make a lens? Are you going to try to use a dispensing or a diagnostic set so you can put lenses on the eye? What type of equipment do you have? Chair time is honestly the biggest one for most doctors that I talk to. How can I fit this into my practice with chair time? So the reason that we're using REMLens in our practice is because it can be fit empirically. We have another fit set in our practice, and I'll say it's actually a dispensing set, but that dispensing set is 15 years old, and it takes up about 4 drawers in my contact lens room, and all of the lenses are dated, and technology has come a long way. So I actually have not had great success with that fit set, and I don't want to invest in a $2,000 fit set that does almost the same thing. So REMLens can be fit empirically with the consultants at X-CEL, and we'll talk about those consultants. They're fantastic. It's a much more customizable lens than we've seen in the Ortho-K space. And the reorders are easy. You can do everything online. There's a calculator online to make things easy. And they're kind of thinking about, or we're rolling out an idea to have diagnostic sets eventually, so that you can have a small set, kind of like in your scleral sets or old RGP sets, where you have a set number of lenses where you can at least get the base curve right and go from there. So the design of the REMLens is very similar to the Atlantis scleral lens, if any of you guys are using that. So the Atlantis scleral lens, we start in the center of the lens and we look at the sag of that lens over the cornea. And then as long as that sag is right, we then work out towards the more peripheral curves, each one of them being independently adjustable. We base the size of the scleral lens based on the corneal diameter, and we go from there. The REMLens is very similar. We start with the corneal diameter here. Using a topographer, we can do a white to white measurement to get the visible iris diameter. And most iris diameters are going to fall between 11.3 and 12.3 millimeters in diameter. And those patients are going to fall into the 10.6 lens diameter. X-CEL has the ability to go up or down on that, and it works very well. For example, I have a 12.4 millimeter cornea, and I was able to do the 11.2 lens diameter. Every Ortho-K lens that I've tried before the REMLens decentered up, my eyelids pulled them up, and then they rocked on my cornea, leaving me with residual astigmatism. But because of this larger diameter size, I was able to get a more stable central fit. And you can really tailor this lens to the patient, even starting from the diameter choice. You can see the options there. There's 5 options as of now. The next part is the optic zone diameter. So in the other Ortho-K lenses that I've been using in the past, the optic zone is set. So it's set either by the manufacturer for any lens of any diameter, or it's set based on the diameter of the lens. With the REMLens, we can manipulate that optic zone diameter to achieve different goals. So what is the point of doing this? Well, there's been some studies, as you can see there at the bottom, that says a smaller optic zone diameter produces smaller treatment zone and a more powerful mid-peripheral steepening, increasing the spherical aberration that affects only the contrast sensitivity, but not the VA. So why is that important? There's a lot of evidence that shows that if the optic zone diameter is smaller and we increase those aberrations as a consequence, the patient can still see well, especially if it's a young myopic patient that jumped the diopter in myopia. They're not going to notice those aberrations quite as much because they're just happy that they can see clearly. And those same studies are showing that we get a better slowdown of myopia rate by decreasing that optical zone diameter. Now, in a different population, say a pre-presbyopic myope with large pupils, we may need to go bigger. So for example, in the lens that I had, I started in an 11.2 diameter and a 6.0 optic zone, but my pupil gets to be about 7 millimeters in the dark. And in another lens where the optic zone was 5.5 or 5 millimeters, I was really struggling. I did not feel comfortable to go out at night. So X-CEL made me a lens that was a 6.4 diameter optic zone. And that made the world of a difference. I was shocked. It got rid of my residual astigmatism. It increased my daytime vision from 20/20 in the other lens, which was kind of a ghosty 20/20, down to 20/15 plus that was very crisp. And my nighttime vision was considerably better. Now with a 7 millimeter pupil in dark, I'm going to notice some aberrations and some halos that I don't normally get with glasses or traditional contacts. But that's something that we just have to educate our patients on. And for me, that sacrifice is worth it because I can still see 20/20 amazing at night with just a slight halo around it. It's just mildly bothersome, and I probably only notice it because I'm so particular about my vision. So being able to manipulate this optic zone is great. And for each diameter, you can go a 0.2 step in either direction. So for example, going back here, this 10.6 lens diameter that is going to fit most of your patients, it comes already with the 6.0 optic zone diameter, which means that you can bump it down to a 5.8, or you can bump it up to a 6.2, depending on your goals, without changing the other curves. Now, the other nice thing here, as we show kind of the demonstration of a traditional Ortho-K lens, is you have the treatment zone, the reservoir zone, the stabilization zone, as we're calling it. So that's where the lens is landing back on the cornea, on the peripheral cornea, and then the dynamic edge profile. So the treatment zone, this is where we start in the center. We put a lens on the eye. We want to make sure that that treatment zone is at least 4 to 6 millimeters across to make sure that we have that good optical clarity that the patient is expecting. Now, unlike the base curve of a traditional GP design, the central treatment zone is used only to flatten the cornea, is not considered a fit factor. So the base curve is determined by the patient's original flat K and their refraction, because it's a mathematical equation. We need to flatten that central cornea enough to make up for the myopia. So it's not a fit factor. We just need to make sure that that lens is centering well with a good treatment zone, and we worry about the fit in the subsequent zones. So we started on the inside, we have a very acceptable treatment zone. So then we move to the reservoir zone. And the reservoir zone usually has a radius of about 0.5 to 1 millimeter. And it's 3 to 5 diopters more steep. The reservoir zone provides an area of epithelial cells and intracellular fluid to collect, and that's drawing those cells out to flatten the central cornea. And this also helps to stabilize the lens. We can raise that reservoir up or down depending on the fit that we need. And then we have the stabilization zone. And this is something that has come in really handy for me quite a few times. We'll get into it with a case study here, but this is something that cannot be easily manipulated in other lenses. And this in the rim lens is an independent zone, meaning that we can change only the stabilization zone and nothing else about the other curves. And finally, we have one of the most unique things about this lens, which is the dynamic edge profile. So as we know in Ortho-K, these lenses have to be a little bit flat at the edge to allow for enough movement so it doesn't get sucked into the cornea overnight. This dynamic edge is tailored to the size of lens that we start with. So if we have a 10-6 lens, it's going to look different than an 11-2 millimeter diameter lens. And we can manipulate that regardless of what size of lens we use. And again, it is independent of the other zones. So if everything else looks fantastic, but the edge lift looks poor, we can change that edge without affecting what the patient will see in terms of movement. Or actually we're trying to tighten it down or loosen it up, but hopefully not change the treatment zone. So there's the dynamic edge profile. And we have standard, steep, and flat, and multiple steps. So just as an illustration, it may be a little bit difficult to tell, but if we look at this lens here, or this eye, this is my eye. And on the left-hand side here, we have a scan from, I guess it was about 3 days ago. And this is me after wearing the REMLens for about 4 days, 4 nights. And so we can see here the optic zone. And it may be a little bit difficult to tell, but this is on the right-hand side, a more traditional CRT or Ortho-K lens that I was using in January. And even that little bit of a difference, it's only about a half a millimeter or to a millimeter larger, has impacted my vision in a great deal. It's made my life significantly easier. And then here's the left eye, same thing. On the left-hand side here, we have my eye from the REMLens, and on the right-hand side, we have that treatment zone from another manufacturer. So what do you need to start fitting REMLens? First of all, topographer. It's a necessity if you're going to be fitting Ortho-K to have a topographer. It's the best way to track and troubleshoot lenses. If the lens is decentered, it gives you certain patterns versus others. So it's really difficult to fit Ortho-K effectively without a topographer. And you want one that measures the visible iris diameter and eccentricity. And you also need an autorefractor or a manual keratometer. Some people say, well, can't I just use the SIM-Ks off of the topographer? And what we found is that those are not as accurate as using traditional autorefractor or keratometers. Fluorescein dye to check the stain pattern, obviously. Ratten filters make that a little bit easier. And then you also want removal plungers. I also try to teach every patient at my clinic how to remove it doing the blink method so that they're not completely dependent on that DMV remover, because the worst case scenario is that you're someplace and you've lost that plunger and you can't get the lens out. Then it's a frantic phone call and a late night visit. So in terms of practitioner training, X-CEL does a great job at making sure that consultants are available through many hours and that you have, as a practitioner, access to troubleshooting guides. And the fitting guide for REMLens is online. It's great. It shows patterns and how to fix problems if you have a decentered lens, if it's decentered nasally, temporally, superiorly. If you only get kind of a half ring on your treatment circle, it does a great job of walking you through what the next steps should be. When you're talking to consultants, you want to do an over refraction. And this is kind of an interesting thing. There's some terminology confusion here. So an over refraction in Ortho-K is still a typical over refraction. You want to put the lenses on the eye and then do a refraction over the lenses. Now, that may seem very intuitive to a lot of you, but sometimes practitioners think, oh, an over refraction is after treatment. So an over refraction is what they're seeing the next morning. That's not the case. An over refraction is over the lenses. So keep that in mind. And you want it to be between about a plus 0.5 and a plus 0.75, maybe up to a 1. to allow for a little bit of regression throughout the day. And then you want to give the consultants a manifest refraction, and this is without the contacts, and give them the time of day, because that's important. You know, if you're a Plano at 8 a.m., you might be a -1 by 4 p.m. if you're a -4 prescription originally. If you can provide a topography or photos, or at least a description of the lens centration and fluorescein pattern, that helps them even more. Staff training. So this is a very important part of how to make this process work in your practice. They need to know why we're doing it, how to screen for these patients, how to handle the lenses, how to teach patients how to get them in and out, and how to capture information reliably. If we can't get good topographies, if we can't get good measurements, then we're going to start in a hole and have to work through it. They need to understand the pricing and policies that you've set in your office, and they're going to be different from office to office. So we'll talk a little bit about that, and how to educate the patient and their parents. So this is probably the longest conversation that I have. My first Ortho-K appointment with a prospective patient is a much longer conversation. We go through what it is, what our warranty is, how it works, the alternatives, and sometimes the studies. There's a lot of scientists in our area, and they actually want to see the studies. So I just have them queued up, ready to go to hand out. And once you get through that initial consultation, really the legwork should fall on your staff. So after that initial visit, I have my staff do everything. They know that when they come in day one, they're going to do a topography. They'll have the lenses cleaned and ready to go. They'll take a history. They'll check the vision and really do the legwork so that I can spend 5 minutes in the room, making sure the patient's okay, seeing how the fit is, and make decisions. Because as a doctor, we're not paid to collect data. We're paid to make decisions. And that's the way that you have to start looking at this in your practice. How can I delegate to make the best decisions? But you also have to be able to trust your staff to make those decisions. So in our practice, we decided on a global fee for the first year of orthokeratology, and this allows for flexibility. It's a cash pay thing, and we allow them to use Care Credit or Sunbit to pay for it because it is a fairly expensive thing. You want to partner with a lab that's going to give you the best prices and warranty and ease of continuation, essentially. Some other practices decide on an a la carte pricing. So if you fit one lens, this is the cost. If we need to go through additional lenses, there will be extra costs. I think that becomes a little bit too taxing on my patients when it seems like they're opening their wallet up every time they come. And my patients have preferred saying, you know, here is the fitting fee, and it will cover all follow-ups, all lenses, and done that first initial fit, we kind of reevaluate and we go to more of an a la carte pricing method. And that a la carte pricing method allows for minor changes as the years go on. You also, if you're going to start these, you need to have a consent form that gives an overview of what Ortho-K is, alternatives, atropine therapy, multifocal soft contact lenses, things like that. Contraindications, so if there's corneal pathology, obviously that's exclusionary. And the limitations, not every Ortho-K patient is going to reach 20/20. I wish they would, but some corneas are more resistant than others. Some just don't get the treatment. We have a lot of patients that are seeing 20/25, but happy in their Ortho-K lenses, and we're still getting the myopia prevention that we need. There's also a risk of regression. So as much as we're trying to slow myopia, I make no promises to how much myopia will progress. So there is a chance that patients will become more myopic. As you're getting into this, you want to be able to get referrals from other providers. You know, we've talked to pediatricians and school nurses and ophthalmologists in our area that we're friendly with, that understand the Ortho-K process and know that we're trying to save them a headache later on down the road. So patient and parent education, again, very, very important. Every time a patient comes in, you want to make change of the note or make notes of the changes. If at all possible, you get a B length 3 while they're in an Ortho-K lens. You don't really have a good way to measure that unless you wash them out every year for a couple of weeks just to see what their refraction is. And that's a very tedious and frustrating process for the patients. And so another way to track myopia progression is through B length. And so a lot of topographers are starting to offer software that can do that. That's a great way to educate patients on how much progression there's been. You also at the start want to talk about what are age-based norms and projected myopia. And this calculator resource here is fantastic. You put in the patient's age, their myopia amount, and kind of see where they go. And that's a great demonstration for parents. I have it pulled up, saved in a bookmark. I just pull it up, put in the patient's information, and then show them the graph. And graphs are pretty powerful when they look at those. So the procedure for this, you have your initial vision or initial visit. You want to do an unaided visual acuity, a manifest refraction like you normally would, a corneal and ocular assessment, and a topography. So in terms of a full exam, the only thing that you're adding is a topography. And if you already are screening topographies on your way in for every patient, great job. A lot of times I have to go back out and ask the staff to do a topography on their way out. But if I can gather all of that information and I'm going to fit the lens empirically, I now have everything I need. And if the patient needs to talk to me and they're on the fence on whether or not they're going to do it, it's a phone call and not another visit that takes up chair time. So once you order the lens, you have a dispensing visit, and this is where you do insertion removal training. Yes, it is easier to do it under anesthesia. I'm sure most of us have had RGPs in our eyes before, especially an extremely flat fitting RGP, and it doesn't feel great. And so you have to warn patients about that adaptation period and how it's going to feel. But sometimes when we're just teaching them how to get them in and out, especially as a young child, we will anesthetize them so they can get used to the mechanics of it. Once the lens is in the eye, we let it settle for about 10 or 15 minutes, and then we do an over refraction. And that over refraction again should land between +50 and +1. We look at the cornea with stain and make sure that the fit pattern is acceptable and that there is no staining or corneal damage. On subsequent follow-ups, we'll have them come in, we'll do a topography, a refraction, VA, corneal assessment, and then over refraction, especially do that over refraction if you're not getting the desired treatment. So make sure that every patient brings their lenses into every single visit, because you never know what you're going to find, and it's much easier to throw the lenses on the eye and try to troubleshoot rather than scheduling a time for them to come back so you can troubleshoot. So follow-up schedule here. I usually have them come in one day after they get the lenses in, and I see them in the morning. I tell them that if at all possible, to wear the lenses in. Now, most of the time, they're not very comfortable in the morning, so they end up taking them out before they come in. But on the occasion that they are in when they come in, it's pretty nice because we can just throw some fluorescein in, make sure that it fit well, make sure that the cornea looks good, and then we can take it out and see how good their vision is with them. And that can be a pretty powerful thing. Depending on the fit, we kind of reevaluate when we're going to see them again. We look at how much treatment we got. You know, I tell parents that what I'm hoping for is on the first night is just improvement. I don't care if it's a half a diopter. I'm just looking for improvement on the first night. Where I've gotten in trouble fitting these lenses is wanting to make changes too soon. You know, if I have a minus 150 myope and the next morning, they're only a minus 125. And I get frustrated and want to flatten that base curve or do something else. That's where I've gotten into trouble and ended up chasing my tail. And I usually end back at the lens that I started with. So you want to give it some time, and you need to educate your patients on this, that it may take 2, 3, even 4 weeks to get the full effect of these lenses. Now, usually it's a week or so, but sometimes it can take a little bit longer, and we're just looking for improvement. So then what do we do during that transition time? I like to tell patients, you know, your child progressed a fair amount in the last year, have them wear their old glasses because they're probably underpowered anyway. So you're getting some refractive improvement with the old glasses. And then I'll see them in a week, and hopefully at a week when I see them and they come into my office, I have them come in the afternoon not wearing the lenses to see what the refraction is at 4 or 5 o'clock. And I'm hoping not to see them in glasses. And that's a good sign when they're sitting in my lobby without any glasses. And then I do a 1 month follow-up just to make sure everything is still healthy. And then I'll do a 3 and 6 month checkup. Now that 3 month is very important, and you want to schedule that in a very strategic way, let's say, because most warranties end at 90 days. And so you want to make sure your last visit is within that 90 days. So if you need to make a final change, you can. So here's a case study that I had that started in 2019. So this girl is a 9-year-old Hispanic female. She is on a Olympic path already at 9 years old for gymnastics. It's pretty incredible. She's homeschooled, and she's in the gym 6 to 8 hours a day in the dusty, chalky environment. And she loves it. I mean, she just absolutely lives for it. Her parents don't even push her. She was begging them to do this. And in 2019, I saw her as an 8-year-old, and she was, you can see her cyclo prescription there. And she's a little bit hyperopic, but I've seen her family. Her dad's about a minus 11. Her mom's about a minus 5. We could all see where it was going. Obviously, I'm not going to start treatment on somebody that has a far-sighted prescription. So in 2020, when she came in, she was minus 1 and minus 125. And I was like, oh no, I know where this is going. I cycled her just in case, because I just really didn't want to. I was hoping that she was just in a ciliary body spasm, because I really was hoping that she wasn't going that direction. But when I cycled her, I got the same thing. So then we talked about it with the family, and I'd kind of talked to them the year before. And I started doing this. You need to talk to these parents early. If you know the parents and they're myopic and their kid is a low hyperope at a fairly young age, you need to be watching it, and you need to be having those conversations early so that they're not shocked and don't get sticker shock when the time comes. Same thing with cataract surgery, right? We can see cataracts coming on the horizon 5 years out before they need surgery pretty easily. And that's when I start having the conversations about multifocal IOLs and toric IOLs, because then they can financially plan for it and they can be ready when the time comes. So I do the same thing with myopia management. So these are her topographies, pre-fitting. Obviously, this was my former topographer. It's not quite as nice as my new one, but those are the topographies. And here again, this spits out some SIM-Ks, but we went with the autorefractor Ks to make sure that it's a little bit more accurate. So first order here, the power was a plus 75. Her cornea fell within the 10.6 diameter range. And you can see the curves from there. Now, when you talk to these consultants, you don't need to know these curves. You just say, hey, it's too flat, and they'll figure it out. So don't spin your wheels trying to figure out the math. At the 1 day follow-up, patient was happy, parents are happy. The refraction in the morning of day 1 was plus 1/4. So even after just one night, she was seeing 20/20 out of each eye individually in the morning. It wore off in the afternoon. When she came back a week later, it was a plus 1/4 at about 4 in the afternoon. The patient she's awesome. I mean, she obviously is very coachable, takes instruction well. She was doing everything on her own at 9 years old, and she was comfortable all night, wearing them all night. It had great movement. It had acceptable movement. It wasn't excessive. It wasn't too tight. There was good treatment zone, and then we had a slight inferior nasal decentration. She didn't have any trouble getting them out in the morning, so I knew that it wasn't too tight. So this is the 1 week topography and a picture of her eye at 1 week. And obviously open eye conditions are going to look different than closed eye, which is why we use the topography. Because when you look at a lens on the eye, when you're blinking and the lens is moving, we may see what looks like a good fit, and then the topography may not match. So here we have a pretty good treatment zone, and you can see that annulus around the mid periphery that allows for a good treatment zone in the center. The fluorescein pattern looks great. She had just pulled it up on a blink a little bit, but it was pretty well centered over the pupil. And if anything, it was actually inferior a little bit most of the time. However, about a week and a half or 2 weeks in, her parents called me and they said, hey, what happened? Everything was going so well, but all of a sudden she just can't tolerate the lenses. She puts them in, takes them out, put them back in, and they don't feel like they did. They're not comfortable anymore. So the lenses, I had them come back in. The lenses began to sag more inferiorly. You can see here that bubble in the reservoir zone down below. It's fitting way too loose here. And this is because the fitting relationship changes. As the cornea changes shape, the fitting relationship may change. And so this is one where it started off fantastic. And then I decided, well, I guess I really do need to make a change. So I discussed it with the X-CEL consultants, and I was able to do a few unique things. I was able to change the alignment zone to make it a little bit steeper. And then we steepen the dynamic edge profile to lift that lens up and make it fit a little bit more tight. And I did this all without messing with the treatment zone or base curve, because she was getting great vision when that lens centered. So if the lens is centered well and we're getting good treatment, that's great news. That's what we want. But if it's great treatment when it was centered, but then starts to move too much, well, then we got to figure out how to make it stabilize without affecting the treatment, which can be difficult in many designs. But, you know, making the stabilization zone a little bit tighter, making the edge a little bit tighter helped. And this is her topography 1 week after the second lens. I think we got a weird reading on the left eye from where she was positioned in my topographer, but the right eye is more accurate of what was seen. And I mean, if that's not textbook, I don't know what is. And she was seeing 20/15 out of each eye individually with a +50 over refraction late in the day. Good comfort. At 6 months, everything remained stable. The over refraction remained stable. That's really the only way I had at the time to check to see if we had any progression, was the over refraction. So the over refraction over the lenses stayed the same. So I can kind of assume that there's not been a change in axial length. She was actually, her cornea was so pliable that she was able to quit wearing them Friday and Saturday nights, which was kind of cool. And because of this and the word of mouth, I was able to get a lot more patients from that gym to come see me, because they were just astounded. All of those girls struggle with a chalky, dusty environment that soft contact lenses are just not conducive for. And so they were very happy. So this is a way to help grow your practice. So, you know, people think, oh, well, if I'm slowing down myopia, they won't need me later on. Well, that's just not true, because you're not going to keep anybody at Plano, and they're going to grow to trust you because you've helped them. You're going to have healthier eyes in your practices. You're going to have less RDs and myopic maculopathy. You'll have an increase in revenue, because this can be a very lucrative endeavor if you have the right systems in place. And then also, you know, a lot of these patients have insurance benefits that they're not able to use because they're doing Ortho-K. So then they can get sunglasses or other products in your office. So the X-CEL difference here. So this is all true. So there's 14 consultants, and they're very well versed in all of the X-CEL portfolio, whether it be Atlantis lenses, regular GPs, multifocal GPs, REMLens. They just seem to know them all, and they have very easy hours to get a hold of them. 8 a.m. to 8:30 p.m. Eastern is pretty easy to get a lens ordered. Doctor-friendly pricing, 90 to 120-day full warranty and full cancellation. Same day or next day turnaround on GP lenses. You don't have to send lenses back every time you remake them. And they have support for you too. So if you're struggling to fit their lenses, they can do things to help you with that, whether it be troubleshooting guides, fitting guides, or even, you know, a wet lab if you're willing to make that commitment to X-CEL to really propel them in your practice. It all saves time and money and streamlines your practice. They also have a unique lens code on them. You can see it there on the radioscope on the right, but on the left there, it shows you what it is. And so anytime you pick up an X-CEL REMLens, you can put it under a microscope or a slit lamp and tell, okay, this is an 8-4 treatment zone. And then by the other numbers, you can decide what lens you're on in case the patient gets mixed up. Because sometimes you have patients that go through 2 or 3 pairs to find the right fit. You don't always know what lens they're wearing. One thing I didn't touch on yet is the toric factor. So as with Atlantis and all other scleral lenses, we're finding that more and more patients do better with toric haptics. Not everybody is spherical, not every cornea is spherical. And so sometimes you need to add a toricity factor into the lens to allow for better centration, stabilization, and the REMLens allows you to do that. We also have a lens selection calculator online, so you can log into your X-CEL account and put in the patient's information as you see there, and it'll automatically calculate the lenses to start with. A lot of times patients ask these FAQs, is it safe? How long will my child have to utilize myopia? It is safe. There's almost the same risk of microbial keratitis as there is with soft lenses. Educate your patients on that. Educate them what to do if a problem arises. They call you. Myopia, how long do we use it for? You know, myopia control, that depends on the patient. It depends on progression. It depends on lifestyle too. I mean, a lot of times we think, okay, axial length hopefully stops around 20 to 22. Maybe we go through college with it. Well, college kids don't sleep very well, at least in my experience, which means that REMLens may not be the best thing for them in college. So maybe we need to reevaluate at that time. But I do have patients and that wear them through their, you know, late 30s, early 40s. I'm one of those patients. I'm in the REMLens now. I came to the game late, but I love it because it makes my life easy. How often do they wear the lenses? Every night, unless they can find out for themselves that they don't need to. How quickly will it become clear? We touched on that. And then what happens if they lose or break the device or the lens? And that's something that you need to set as a policy in your own practice in terms of warranty replacements. X-CEL will stand behind their work, and you know, if there's a manufacturer defect, they'll take care of that within a certain window. And if they lose one, maybe you cut them a deal. But you do need to make sure you have those policies set and have them educated on the front end so there's no confusion. So that's what I have. Hope you guys learned a little something, and I'll let Kathy talk for a minute.
Okay, thank you so much, Nick. We have one question so far. How long does it usually take to get full correction for a myopic patient with a -5 correction who is not an adolescent?
That's a good question. You know, -5 is really pushing the limit of what good vision will get. I would say in my experience, it takes the full 2 weeks sometimes I'm surprised and you have a week plus or minus, but give it at least 2 weeks, if not 3. And the difficult thing is if it's not an adolescent patient, what does that patient do in the meantime, right? Because you can't be a -5 35-year-old working in a warehouse that is a minus, walking around as a -2 because the full correction hasn't hit. And so sometimes with those patients, what I'll do is I'll have them come in weekly or even 2 times a week just to kind of check where they're at. And then we'll give them daily disposable lenses that they can use to try and bridge the gap. Or we can cut them a pair of single vision, simple lenses that are kind of halfway in between treatment and halfway not.
Okay. Next question. If the cornea is thin, how does it affect it?
Faster treatment. Thicker, sturdier corneas, just like taking pressure, it takes more to indent them. Whereas thinner corneas, it's a little bit less time. So it's just a little bit quicker, and then a lot of times they'll be a little bit more pliable, whereas the thicker corneas tend to be a little bit more resistant to change because there's so much stroma underneath there. But sometimes they hold their shape better too. So.
Okay, it looks like that's all the questions we have. All of you that have attended the meeting, you'll be receiving an email follow-up and with instructions and how to take, if you're interested in taking the certification test and what the process is. And once you get certified, you will receive your first lens free. So make sure you get on there, take your certification, and we will send you your first lens free. We also will have some educations. We'll customize it for your office. It's called Feed Your Mind, whether you'd like it for practice management or a refresher on, some fitting. We can, fill whatever needs you have. I see no other questions, so that's it for tonight. Thank you so much, Nick. And please contact us at X-CEL if you have any questions. Thank you.
Thank you, guys.